When talking about endocrine disorders, of course, diabetes is the big boy. When it comes to physical therapy, we see it in a lot of our patients, but there are also other endocrine system disorders that we will run across. And so we're going to talk about the different ones and then some physical therapy considerations in general for endocrine system disorders. So, like I said in the introductory lecture, usually it's a hypo or a hyper issue. So hypo is you don't have enough of the hormone, and hyper is you have too much. So we'll just talk about the different hypos and hypers and what the effects of them, what the causes and effects of them are. So parathyroid hormone is a big player in calcium metabolism. So when you have hypoparathyroidism, it leads to hypocalcemia. So when you need calcium circulating in the blood for muscle contractions, particularly cardiac muscle contractions, and for nerve impulses. So if you have hypocalcemia, you have weak cardiac muscle contractions and increased excitability of nerves. So sometimes you'll get muscle spasms, spontaneous contractions of those skeletal muscles. Hypoparathyroidism can be caused by a parathyroid tumor. It can be caused by congenital lack of a parathyroid. It can be caused by surgery or radiation in the neck region or autoimmune disease. So hyperparathyroidism, the opposite, results in hypercalcemia, which causes forceful cardiac contractions, potentially osteoporosis, and predisposition to kidney stones, and sometimes stones in other organs as well. Hyperparathyroidism can also be caused by a tumor. So the hypo is caused by the tumor that is killing tissues around it and not enough hormones getting produced. Usually the hyper is caused by a tumor that's producing excess amounts of the hormone. Sometimes you'll get hyperparathyroidism secondary to renal failure, or paraneoplastic syndrome, which we just talked about, where the tumor is producing a bunch of the hormone. So these are the effects of parathyroid hormone imbalance. So hypoparathyroid causes hypocalcemia. There's a typo on that slide. Anyway, hyperparathyroid causes hypercalcemia. And there's the list. So, that's interesting. I'll have to write to the publisher on that one. That's straight out of the book. So, pituitary hormones, most of the time, pituitary disorders are caused by adenomas. So they're caused by tumors of the pituitary. So the effect of a pituitary mass can cause pressure in the skull, causing headaches, seizures, drowsiness, or visual effects. It can, depending on the cells that are affected and the location, it can cause excessive or decreased release of hormones. So from the introductory lecture, we know that the pituitary secretes a lot of different hormones, and so excessive or decreased release of hormones can cause a lot of different problems. So growth hormone is one of the ones. Dwarfism is a deficit in growth hormone production and release, and is often congenital. Gigantism is excess growth hormone prior to puberty and prior to fusion of the epiphysis. Acromegaly is excess growth hormone secretion in adults, and it's often associated with adenoma. The bones become broader or heavier, and the soft tissue grows. A lot of times you see enlarged hands and feet and changes in facial features. One of my cousins actually had acromegaly associated with an adenoma, and she ended up having to get a jaw surgery to get part of her mandible removed because it had grown to the point where she was having malocclusion with her teeth. But after that surgery, and they did radiation and surgery on the tumor and were able to get it, and she didn't have any further problems with it. She was taller than the average, but That's the only in that jaw surgery that she had to have. So it can be caused by that tumor, or it can be caused by congenital things. There was a few years ago, there was a guy in Ellensburg, Washington, that was considered the world's tallest teenager, and he had an adenoma, and they were actually treating it with medication, or that's what I read. So that's how gigantism was kind of his effect, because it happened prior to puberty. And they were able to successfully treat it with medications and stop his excess growth. So this is sort of the spectrum from excess to deficit in growth hormone. Antidiuretic hormone, or ADH, or vasopressin, the deficit of it is diabetes insipidus. It's often caused by an adenoma. It may originate in the neurohypophysis. After a head injury or surgery. Sometimes it's a genetic problem. Replacement treatment is required there, and then figuring out if it's caused by an adenoma, treatment of the adenoma. But no matter whether it has an adenoma or not, you have to replace the missing ADH. There's a medication that does that. Excess ADH is called inappropriate ADH syndrome. It may be temporary, triggered by stress, or it may be the ADH is being secreted from an ectopic source, such as a tumor. And ectopic means just out of its normal area. So instead of being secreted from the hypothalamus like it's supposed to be, a tumor somewhere is secreting it. So excess ADH is treated with diuretics and sodium supplements. So thyroid disorders, a goiter is an enlargement of the thyroid gland. There are different types of goiters. There's an endemic goiter, which is hypothyroid condition, and it used to be seen a lot in regions with low iodine levels in soil and food. Now that it's more widely known what causes that, there are iodine supplements, and people who eat a lot of fish get iodine, or sea vegetables get iodine from that. Goitrogens are foods that contain elements that block the synthesis of some of the thyroid hormones, and those cause enlargement of the thyroid gland. Sometimes you get a toxic goiter that results from hyperactivity of the thyroid gland, and that can be caused by a tumor as well. So hyperthyroidism, too much thyroid, is called Graves' disease. It's related to an autoimmune factor. Hypermetabolism and increased stimulation of the sympathetic nervous system. So increased body temperature, sweating, soft, silky hair and skin, reduced body mass index, insomnia, and hyperactivity. So a lot of times people's first inkling that they have hyperthyroidism is they start losing weight and they feel hot all the time. With hyperthyroidism, you can also get a toxic goiter, and this is later signs of it, which is, toxic enlargement of the thyroid, and exophthalmos, which is protruding eyes, decreased blink and eye movement, and it results from an increased tissue mass in the orbit and may result in visual impairment. So that's one of the signs of long-term Graves' disease, untreated. Hypothyroidism can be an iodine deficit. It can be Hashimoto's thyroiditis, which is an autoimmune disorder. It could be caused by a tumor or surgical removal or treatment of the gland. Cretinism is an extreme form of hypothyroidism that results in short stature and severe cognitive deficits. It's an untreated congenital hypothyroidism, and it might be related to iodine deficiency during pregnancy. So the manifestations of hypothyroidism are goiter if it's caused by an iodine deficiency, intolerance to cold, increased BMI, so it's kind of the opposite of the hyperthyroidism. Lethargy and fatigue, decreased appetite, and mixed edema in severe untreated hypothyroidism, so it's non-pitting edema in the face and a thickened tongue, and sometimes it can cause acute hypotension, low blood pressure, hypoglycemia, hypothermia, resulting in loss of consciousness. It can be life-threatening if untreated. So this chart from the book compares hypo and hyperthyroidism, and they're almost the exact opposites of each other. In the hormone levels, the metabolic rate, the skin, when it's low, it's pale and cool. When it's high, it's flushed and warm. Cold intolerance with hypo and heat intolerance with hyper. Bradycardia with hypo and tachycardia with hyper. So they're almost mirror images of each other. The adrenal medulla, there are different syndromes that are affecting the adrenal medulla. One is pheochromocytoma, which is a benign tumor of the adrenal medulla, but it secretes epinephrine, norepinephrine, and possibly other substances depending on the tumor. Sometimes it's multiple tumors. So epinephrine and norepinephrine affect the sympathetic nervous system, so sometimes you get the headache, the heart palpitations, sweating, or anxiety, because it's stimulating your fight or flight response, basically. So Cushing's syndrome is caused by an excess level of glucocorticoids from adrenal pituitary adenomas and ectopic carcinoma, so another carcinoma that is excreting excess glucocorticoids, iatrogenic conditions, so things caused by other treatments, other medications, or substance abuse can cause Cushing's syndrome. So a lot of times someone's face becomes round. Sometimes they'll call it a moon face with a ruddy color. Truncal obesity with a fat pad between the scapulae, thin limbs, thin hair, and fragile skin. There's a picture in the book. Let's see, did I put it in here? No, I didn't. There is a picture in the book of typical Cushing's disease. And I'll tell you what page it's on. It's on page 425. So it's just that description, it shows that. So the metabolic effects are retention of sodium in water. That might cause that rounded effect. Suppression of the immune response. Stimulation of erythrocyte production. Emotional lability and euphoria. So someone who cries easily or goes from one emotion to another really quickly. There are other things that can cause that too. Increased catabolism of bone and protein, so that's increased breakdown of bone and protein, and delayed healing, and increased insulin resistant and possible glucose intolerance. So Cushing's syndrome has widespread effects throughout the body. Addison's disease is the opposite. It's a deficiency of adrenocorticoid secretions. It's usually an autoimmune reaction that causes it, and or the adrenal gland is destroyed by hemorrhage or infection. So it causes decreased blood glucose levels, inadequate stress response because your sympathetic nervous system is being understimulated. It can cause fatigue, weight loss, frequent infections because your immune system is understimulated. Low serum sodium concentration, which causes decreased blood volume, hypotension, and high potassium levels. So this is a comparison of Addison's and Cushing's. So with the endocrine disorders, there's often a hypo and a hyper, and you can kind of compare the two. So sometimes it's kind of nice to, and I did this in the module, there's some tables comparing hypo and hyper of different diseases. So sometimes that's a nice way to think of it is, well, what's the hypo and what's the hyper and how do they compare? So for endocrine disorders, no matter what the disorder, the primary physical therapy goals are to optimize functional mobility, to maximize activity tolerance and endurance, to prevent skin breakdown in the patient with altered sensation, like with diabetic neuropathy, to decrease pain in patients with osteoporosis and hyperparathyroidism, and to maximize safety for prevention of falls, particularly in patients with altered sensation or muscle function. So pretty straightforward PT goals. So there's nothing that we can do to directly affect the hormone levels to increase or decrease them, except maybe with some of the exercise effects with diabetes. But we have some pretty common goals for all these people. We want them to have good activity tolerance and endurance, good functional mobility, and to maximize their safety and decrease their pain and prevent skin breakdown. So a lot of times with these types of disorders, that's really the goal, is we're trying to prevent complications. We're trying to prevent other problems, and we can do that.